Hi everyone, my name is Dr. Fatima Elena, and today the purpose of making this video is just create a general awareness about a pathology called thyroid carcinoma. These are the outline for today's video. Before we dive into the pathology of thyroid carcinoma, let's just go through a brief overview of the normal anatomy and the physiology of the thyroid gland. Now, the thyroid gland is a butterfly-shaped organ which is present at the base of the neck anteriorly. It's present just below the Adam's apple. And as you can see from this picture, it's wrapped around the trachea. It's hugging the trachea. A structure that's hidden in this picture is just behind the trachea is the esophagus. Now, keep that in mind when we talk about the patient with a suspected thyroid cancer presenting with compression symptoms. Now, there are 4 compression symptoms that are mentioned over here, which are hoarseness of voice, difficulty swallowing, persistent cough, dyspnea, which is a medical term used for shortness of breath. Now, you can link all these symptoms in close proximity of the thyroid gland with the trachea. Now, because the cancer is growing, it's going to apply pressure on the trachea, which is going to result in difficulty breathing, shortness of breath, persistent cough, and the rest of the symptoms as well. The patient may also present with throat pain or discomfort, enlarged lymph nodes. If it is a hyperfunctioning nodule, then the patient is going to present with hypothyroid signs and symptoms, which may include weight loss, intolerance to heat, increase in appetite. They may also have systemic signs, which includes unexplained weight loss and fatigue. Now, there are certain risk factors that are associated with thyroid carcinoma, which includes radiation exposure, especially during childhood, age, iodine deficiency or excess, genetic syndromes, environmental exposure, family history of thyroid carcinoma, or personal history of thyroid carcinoma. Now, one very interesting fact about radiation exposure is that there were several studies conducted which showed the incidence of thyroid carcinoma closely linked to the region of Chernobyl due to the extreme exposure of radioactive iodine in children, which resulted in 5 to 10 years later after the exposure in thyroid carcinoma in those children. Now, the initial investigation of how a doctor is going to proceed with a suspected case of thyroid carcinoma is going to start off with inspection, upon which the doctor is going to see asymmetrical swelling. Second step includes palpation, upon which single or multiple nodules can be felt on the neck, which may be midline or laterally positioned. Now, usually a confirmation of whether or not a nodule is malignant or benign, whether or not it is a cancer or not, is usually done with the help of investigations. But sometimes palpation, just upon examining, you can sometimes rule out whether or not it is a malignancy or not. Now, if the nodule on the thyroid gland is tender, it's usually going to indicate that it's a thyroiditis or hemorrhage, unlikely for it to be a malignancy. Whereas if it is hard or fixed, it's usually inclined towards it being a malignancy. Now, there may be signs of local invasion as well, which includes palpable lymph nodes, tracheal deviation, or dysphagia, which is difficulty in swallowing. Now, we're going to proceed with investigations. Now, the first and foremost investigation to do is the TFTs, which are the thyroid function test. Now, upon expected malignancy, the TSH levels are going to be normal or elevated, and if they are suppressed, we need to consider an additional test called scintigraphy to assess for a hot nodule. The purpose of scintigraphy is to find out whether or not the thyroid nodule is hot or cold. Now, the difference between a hot or cold nodule is how much radioactive iodine is being taken up by the nodule. Now, if it is absorbing a lot of radioactive iodine, that indicates hyperfunctioning nodule, which shows that it is a benign condition. Now, opposite to this, if the uptake is low, it indicates hyperfunctioning, resulting in a malignancy. Now, there are different approaches to a hot and cold nodule. A hot nodule is going to be approached by radioactive iodine ablation, whereas a cold nodule is going to be preceded by FNAC to confirm the diagnosis of malignancy. The next step to look into the investigation is with the help of a thyroid ultrasound. Now, the purpose of ultrasound is to assess the structure and the extent of the spread of the cancer. And one of the scores that we use is a graded scoring system, which is based on ultrasound findings on how to proceed it, which includes composition, echogenicity, the shape, margin, and echogenic foci. Depending on the different scores according to this graded levels, we are going to proceed in the corresponding manner. The next step to focus on, depending on the ultrasound findings, is the FNAC, which is usually done to find out the nature and the type of carcinoma, which further helps in aiding which kind of treatment we need to proceed with. Now, another score that we follow with the FNAC is a Bethesda score, which is a cytology-based categorization. The Bethesda score helps us in assessing the risk of malignancy and how to manage, how to proceed with what kind of treatment. Now, further investigation include tumor markers, which isn't done as an initial investigation. It's usually done to check for reoccurrence for post-thyroidectomy surveillance. Further imaging apart from the ultrasound includes CT and MRI, which is usually done in case of extrathyroid extension for detailed anatomical involvement. Now, the management includes surgery, radioactive iodine, thyroid hormone suppression therapy, EBRT, which is external beam radiotherapy, chemotherapy, targeted therapy, and palliative care. Now, surgery, this is the first and foremost treatment option that doctors usually aim for. Now, how to distinguish between whether or not a patient is going to have a lobectomy, which is just the removal of a single lobe, or a total thyroidectomy. It depends upon the findings of the ultrasound and FNAC. If the size of the involvement of the cancer is less than 1 centimeter and it's just confined to one lobe and there are no extra thyroid extensions, chances are the doctor is going to aim for a lobectomy. Whereas everything opposite to this, if it is more than 1 centimeter or higher risk, including multiple nodes, extra thyroid extension, or lymph node metastasis, or if it is more than 4 centimeters, regardless of the other findings, a patient is usually going to undergo a total thyroidectomy. Radioactive iodine is usually done, it's available in multiple availabilities. It can either be oral capsule solutions or IV injections. It is completely contraindicated in breastfeeding or pregnancy patient because it can result in the fetus having congenital hypothyroidism. The next step in management is thyroid suppression therapy. Another treatment option includes the external beam radiotherapy, the EBRT, which is usually indicated for inoperable or locally advanced tumors. This is usually indicated in unresectable tumors and is usually aimed for palliative care in advanced metastasis. The aim for the doctor in this case for the patient is to get rid of the pain, bleeding, and airway obstruction. Another treatment line involves chemotherapy, targeted therapy, and palliative care. The follow-up is usually done by clinical evaluation, thyroglobulin and anti-TG antibodies, TSH monitoring, calcitonin and CEA, neck ultrasound, radioactive iodine, whole body scan, and cross-sectional imaging, along with laryngoscopy. The aim of follow-up is to find out whether or not this cancer has completely been eradicated or whether or not it has reoccurred. Depending upon the time frame, there's different frequencies of when you are going to do all the follow-ups. Now, within the first 1 to 2 years of treatment, the frequency of follow-up, which includes the clinical evaluation, the tumor markers, and ultrasound findings, includes 3 to 6 months occurrence. Now, after the first and second year, between 3 to 5 years, the investigation is going to be done at a frequency of 6 to 12 months. After 5 years, it's going to be done every 1 to 2 years. Now, the prognosis of thyroid carcinoma usually depends upon the kind of cancer that the patient has. In case of PTC, which is papillary thyroid carcinoma, it has excellent prognosis, 10-year survival rate, and more than 95% treatment. Similar for follicular thyroid carcinoma, it has good prognosis. Now, the worst kind of cancer, which has worst prognosis, is the anaplastic ATC, which has median survival rate between 3 to 6 months. The good prognostic factors involve young age, small tumor, no metastasis, well differentiated, whereas everything opposite to this includes poor prognostic factors. Thank you for your time. I hope you learnt some new information about thyroid carcinoma.